Good morning, everyone, and welcome to HGIS Partnership for Patient Care Safety Forum webinar entitled Preventing Suicide, Assessment, Environment, and Risk Mitigation. My name is Liz Owens, and I serve as a project manager for the Healthcare Improvement Foundation, and I'm also joined by my fellow colleagues Pam Braun and Claudette Funchal. For those of you who are not familiar with HGIS PPC, the Partnership for Patient Care is a unique collaboration between Independence Blue Cross and the region's hospitals that provides programming and facilitated learning collaboratives specific to quality and patient safety improvement, with the ultimate goal of making this the safest region in the country. As a PPC collaborative, the Safety Forum program engages people like yourselves, the frontline leaders in risk management, patient safety, and quality, to examine safety hazards and vulnerabilities, and then to share strategies, tools, and processes to overcome such challenges. On today's webinar, you will hear from Nancy Napolitano, a patient safety analyst at ECRI, who will be presenting on suicide prevention in the acute care setting. We will hear from Nancy about the ever-growing importance, especially amidst the COVID-19 pandemic, of focusing on and addressing the mental health needs of healthcare workers, patients, and community members as it relates to suicide prevention. We're delighted to have everyone with us for today's webinar representing our many PPC partner organizations. Just before we get started, I'd like to review a few housekeeping items. Today's webinar is 1 hour in length. You can access audio for this webinar either through your telephone or your computer. Everyone will be on mute for the hour, and should you have any questions throughout the webinar, we just encourage you to type them into the chat. We are recording the program, so all registrants will receive an email following this webinar from myself with the recording link, a PDF copy of today's slides, and then a link to an evaluation. And we ask that you please take a moment to complete this evaluation, as your feedback will be very helpful in measuring the effectiveness of our PPC programming and suggested future topics. At this point, I'd like to introduce our speaker. As I said, Nancy Napolitano currently serves as a patient safety analyst and consultant at ECRI. With over 35 years of behavioral health experience in successful programming and collaboration for patient safety and satisfaction, Ms. Napolitano's specialty is in behavioral health and workplace violence, suicide, and safety. Prior to joining ECRI, she worked for 20 years managing inpatient and outpatient adult and geriatric psychiatric programs within acute care hospitals in suburban Philadelphia. In these roles, Ms. Napolitano built cross-functional teams that focused on internal and external patient and resident customer satisfaction. She served on patient and employee hospital safety committees, and she implemented positive changes on the behavioral health units, emergency departments, and medical floors to treat comorbid conditions. Ms. Napolitano also served as a master trainer for staff on violence prevention and de-escalation techniques to increase awareness and reduce patient and staff harm throughout the organization. And now I will hand it over to you, Nancy.
Thank you, Liz. I'm working on converting over. Okay. Can you see that fine?
Yes, Nancy, maybe we want to just view it in slideshow mode, please.
Okay, sorry, I thought that's where we were. Okay. I'm sorry. I want to pause the recording a minute. All right, I'm going to have to stop for a second.
Nancy, I'm happy to share if you'd like me to share. I can do that.
Yeah, why don't you do that? I don't know what happened.
Sure.
That'd be fine.
Let's give this another try. Okay.
There you go. Perfect. All right. Thank you, everyone, for being here today to listen to the most important topic we have here is suicide and the increase that we're going to be seeing. So next slide. Okay, so the objectives for today, we're going to start looking at the type of distractors that may prevent suicide risk assessments from being completed and why we're not doing them regularly. We're going to compare and contrast the differences between the suicide screening and suicide risk assessment because they are not necessarily the same. We want to look at some evidence-based suicide strategies and some treatment modalities for the prevention. Learn about the important role that sitters can play in suicide prevention, understand the components of successful discharge plans for behavioral health patients with risk factors. Some of the problems we see is that they don't have good discharge follow-up, which creates a difficult situation once they leave the hospital. And we're going to take a look at the toll that COVID-19 pandemic is having on mental health, well-being, and on suicide. So death by suicide, more than a mental health concern. There have been 47,000 deaths, 47,000 lives lost to suicide in 2017. 1.3 million attempts. The leading cause of death, second among people ages 10 to 14 years old. These are children, 10 to 14 years old, committing suicide. And worldwide, and 10 to 34 in the United States. So you can see that we have this growing problem. It's been going on for a while, and it's increasingly progressing to almost a pandemic state. Between 2000 and 2017, the rates increased by 33% across the United States and 50% among women and girls. These statistics are pretty sobering and definitely something that we need to start paying attention to a little bit more. Next slide. Okay, so here's some thoughts for you to think about. For every person who dies by suicide, there are 280 people thinking seriously about it, but not following through. And this is according to the National Suicide Prevention Lifeline, which has increased their numbers dramatically since the COVID-19 pandemic. And 9 out of 10 people who attempt suicide and survive will not go on to die by suicide. However, suicide previous attempts are risk factors that we need to keep in our minds when we're addressing patients. Next. So now we have COVID-19 and suicide, and what happens when we have this national pandemic and people are forced to stay home, and how does it align with the national suicide crisis? So secondary outcomes of the COVID-19 pandemic are inevitable. They are going to have a dramatic effect on everyone's mental health, whether you're a patient, whether you're a caretaker, or a caregiver, a provider. And what we don't realize is that people who don't have mental health issues identified will have some kind of residual effect from the pandemic. There are multiple stressors. We're going to see a lot more PTSD. There are financial stressors, environmental. There's limited access to mental health treatment. Right now, I'm seeing a lot more of companies and organizations who have people working from home providing some kind of wellness to their employees, whether it's through their EAP or just webinars or just resources for them to use to reduce some of the stress that occurs when your life suddenly changes in very many directions. And all of this is coexisting with that rising suicide rate, which is going to only accelerate the crisis. The suicide has increased by 35% between 1999 and 2018, which is the recent data from CDC. Medical professionals are starting to become one of these statistics because of the stress of every day caring for people who are dying, 40-year-old people who in their minds should not be dying and they are dying. And there isn't very much that they are doing to deal with that grief, because the crisis is just so pandemic in nature that they have to just keep working in crisis mode. So by the time they stop to think about anything, this is when all those thoughts come, the thoughts come flooding in, and nothing to do with them. So mental health experts are saying that now it's time to really normalize the conversations about suicide. Suicide has always been one of those topics that you don't use the word, and you know, do you feel like you're going to hurt yourself? We really need to start calling it what it is to identify what the severity of it will be. Next slide. Suicide is a patient safety problem. Oftentimes you have suicide assessments and people check the box. They make sure they do it, but do they really give a lot of thought into what they're screening for and what they're assessing for? The screening should be for every patient who receives medical care in the EDs and medical hospitals. It could be a short version, 2 questions. Patients who present with suicide attempts or overdoses or intoxication or repeated visits, gestures, attempts, should all receive that comprehensive risk assessment, which is an assessment to really identify the risk versus whether they need are they having something that we should look further into. And even if they deny suicidal thoughts, you need to do that more in-depth assessment, because most people are embarrassed that they might be wanting to hurt themselves, suicide or kill themselves, or there's a lot of guilt surrounding those thoughts. And if they really are intentional and want to want to commit suicide, they're not going to tell you. If they've already gotten themselves to a point where they just are convinced and going to go, they're not going to tell anybody because they don't want that help. Next. So this was an interesting quote from Dr. Lieberman, who is a psychiatrist. In no other field of medicine is a person's prognosis for an illness so determined by the availability of healthcare services. Mental health resources, as we all know, are slim to none in many areas, and even in the best of areas where there are plenty of healthcare services, mental health is not one of the top 10 that are available. It's very limited. We've done a better job. Telepsychiatry has been a major asset through all of this, but we are not doing a good enough job in making sure that people get the kind of care that they need. It's not like a regular illness where a monthly or every 2-month visit might be enough. Sometimes in the beginning, they need a little bit more frequency to keep the person on track. Next. So what brought us to all of this, and I think what raised a lot of attention for those hospitals who are accredited by the Joint Commission, the National Patient Safety Goal 15 requires that these risk assessments and risk factors be identified. So when we look at the risk factors, there are 6 or 7 different types of risk factors that we really need to look at. It's not just one component, it's many components. We have to look at their familial, their community, their cultural supports, individual, biological, and what are the societal needs that this patient may have. Next. So when the Joint Commission put this in and increased their requirements to this, hospitals had to really take a look at their environment and, what is safety? What is the environmental safety that's necessary for a patient who has a suicidal thought or thoughts of hurting themselves? So these risk factors are characteristics of a person that increase the likelihood that he or she will die by suicide. So as you can see, I'm not going to read them all, but all of these risk factors, if you have 1, if you have 3, if you have 6, can complicate the need for care, and it can complicate identifying the person that may need something more than they already have. Next slide. So here we have contributing factors. And if you think about all of these contributing factors that are in this slide, think about how many of them are happening now through the COVID-19 pandemic. We've got people who are losing their houses, people who are losing their jobs. They have no finances coming in. They are increasing their use of substances, relationship problems. I just read this morning that in Dallas, the rate of domestic violence has increased. That was just a story that I saw come across this morning. People who have physical health problems might not be able to get the care they need because the focus has really been on COVID, and doctors are not necessarily seeing people. They might be doing telehealth, which has been astronomical in being able to keep people at as well as they possibly can. Crisis and criminal and legal problems. So all of these are just exacerbated during this pandemic. Next. So let's talk about the reality of suicide. Can we predict it? No. The reason that it's not predictable is because it's not like a broken leg where a bone needs to be reset, you cast it 6 weeks, everything's good. Patient's back to normal. When people are depressed or they're having PTSD or they're having other signs of mental illness, sometimes they're not as apparent as a broken leg. And sometimes it takes a lot of trust to get to the part where that patient is willing to open up and to give you what they need in order for you to treat them appropriately. And there's no completely valid and reliable tool to assess or prevent suicidality. We have assessments that can give us an idea, that can give us a risk factor or a risk score, but nothing really can reliably tell you whether someone is going to or not going to commit suicide. It is the 10th leading cause of death in the US and has been for a few years now. Military and veterans, another population with much mental health, much like what we're dealing with in the pandemic. They represent 20% of all suicides, but they're only 1% of the population. So the average is 22 suicides a day of military and veterans of military. 31% of that population and 24% of the 31% of the clinical population, 24% of the general population attempted suicide. So if you look around you and you look at one every third person for clinical, or one every approximately 4.8 person in the general public has attempted suicide. Those are pretty astronomical numbers. And I think it's time that we really have to not be afraid to ask the questions and to use the real language. Because remember, interpretation of language is not going to give you what it is. If I say, do you feel like hurting yourself? Well, no, I don't feel like throwing myself down the steps, but do you mean, do I want to shoot myself? Maybe. So it's really important that you say what you mean and let the patient answer the question. Next. So going back to the Joint Commission requirements, what they're requiring is that you have thoughtful evaluation of your environment, meaning that you may have 10 bays in the emergency department and you may have 2 patients coming in with suicide ideation. What do you do with those 2 patients? Do they go into a regular bay? Do you have identified bays that are, or beds that are identified just for patients who have behavioral health or psychiatric issues? Do you have someone on a one-to-one? So you really have to think about your environment. Are the doors, the exits very close? Take a look at how you can successfully treat someone without endangering them if they were to get a hold of something that's hanging or can elope through a door. And then a plan. What is the plan for that patient? And what are the resources to guide your staff when you're housing the patients at risk for suicide? Are there checklists? Are there lists that you can say, here, these are the things that should never be in the room when this patient is in this room, or here they're getting their meals, but they shouldn't have regular silverware on the meals. They should have, maybe disposable, but let the staff know that they have to count those things to make sure they're getting them back. And I have a few case studies a little bit later to kind of show you how quickly something can happen. Next. So the additions that they added to their patient safety goal 15 was the environmental assessment. Everyone must do an environmental assessment of the area. Suicide assessment of patients who screen positively. So if you ask them the 2 questions and one of them is yes, then you need to go to a suicide assessment. And I'll show you some of the assessments that are available a little bit later. Staff training for assessing and monitoring patients at risk. And through all of my experience with behavioral health, the one thing I always made sure that staff knew is that they have to trust their gut. So if something doesn't feel right, despite what the patient is answering, you need to make sure that you're comfortable with the answers or get someone else in there to help decipher whether or not this patient is a true risk. Because as I said before, they won't tell you if they're truly, truly going and have made their mind up to commit suicide. And the discharge and planning and follow-up care is most important. And back a long time ago, you used to have to get an appointment within 7 days. But think about that. If you have a patient who's suicidal, that it has reduced some of their suicidal ideation while they've been in the hospital, now you're putting them out and they don't have a follow-up or a touch until 7 days. You're leaving a major gap for something to happen within those 7 days. So it's really imperative that in your discharge planning and your follow-up care, that you make a contact point with the patient to talk to the follow-up person prior to them leaving your care. Connection is a very important thing. If they know who they're going to see and they've talked to them, that connection is better than just a name on a street that you have to go to in 7 days. So really think hard about what is their aftercare when they leave you. Next. So some of the suggestions that came from the Joint Commission, and I realize that not everyone is Joint Commission accredited. I have used these because they are really pertinent to what's going on today. Some people have other accreditations and that, that's fine. I'm sure they're very similar. You have to make those checklists that I identified earlier. Make sure that the person in that room, everybody who goes in that room and goes out of that room, knows that that patient is a suicide risk. You need to make sure some of the poles aren't just there, they're not being used, they're just hanging in the room. Those are all hanging points that a patient can get. Competency and training for all sitters. What's really important and what I've seen so much in the medical hospital is that the sitters are just either people who are working in another department, they just need somebody to sit with the patient to make sure they don't hurt themselves. The reality is the patient doesn't want you sitting there staring at them. Engage with them, have a conversation, know what you can say, what you can't say. So that competency and training is imperative to make sure that the sitter treatment plan works. Patients want to engage. Patients don't want to feel like they're, different than the rest of the world. They want to know that the person who's with them cares about them. And it's I can't stress this enough, that engagement with that patient is much better than not. The visual reminders, posters, significant risks on the unit. Let everyone know who's walking in that room that that patient is a high risk for suicide. And having an on-site psychiatric professional who's available is always the best idea, and doing environmental risk assessments. But I do realize that you don't always have the psychiatric professionals on site, especially if you don't have a psychiatric unit in the medical facility. Next. So let's look at the numbers. 1.7 million per year was saved by one hospital adding a behavioral health provider to its inpatient medical team. 68% of adults with mental disorders also have comorbid physical health conditions. 29% of adults with physical health have mental disorders. And 42% of inpatients with physical complications also have the co-occurring mental health or substance use disorder going on. That's nearly half of our population in the hospital. Next. So going from suicide risk screening versus assessment, the screening brief question tool to identify whether an assessment is necessary. It can be completed as part of your health questionnaire. It can be just 2 questions at the bottom. Do you feel like committing suicide? Do you have a plan? Those 2 questions. Does the patient have risk factors or symptoms that need further evaluation? And then the assessment is a little bit more in-depth question, the where, why, how, and it refers to more than one comprehensive evaluation done by a clinician to confirm the suicide risk, estimate the danger, and this is why there is no tool that is completely valid, because it's an estimation of the immediate danger, because no one really knows what that will look like. And then decide on your course of treatment. It's a synthesis of multiple acute, chronic, and modifiable risk factors. Evidence-based suicide prevention strategies are easily used in emergency departments. A lot of emergency departments are now putting in metal detectors to make sure that firearms aren't coming in, lethal medications aren't coming in, hotspots for suicide by jumping. There's all kinds of things that can be done to prevent some of the means of suicide from entering into your hospital. And transitions of treatment are a huge place for suicide to occur. When people are going from one part to the next part, from inpatient to outpatient to partial clinic, residential programs, those transitions are also opportunities for the person to lose sight of the treatment. So it's really important, as I said before, about the handoff. Make sure that the patient is handed off to the next service provider, whether that's through a phone conference call, whatever that may be. Maybe someone can pick them up and take them right to the appointment if that's possible. So these are all things to look at when you're doing your assessment and you're doing your screening for the assessment. Next. So some of the assessments out there, you have a behavioral health history that you do on admission. There's a depression scale that's used by some, and everybody has their own scales that work for their facility. Some people have these scales right into their systems, their EHR systems and RMIS systems, so that they can just bring it up on the screen and complete it. So the PHQ-2 is a 2-question assessment, and the 9 is a little bit more with 9 questions. The suicide assessment that tends to be used a lot is the Columbia Suicide Severity Rating Scale, and it's probably one of the most comprehensive suicide scales, and a lot of people are adapting that and adopting it into their facilities. And then I just put these in here because, I get a lot of questions from members and from hospitals about, how do you know someone's going to become violent? How do you know that they're a danger? So I just like to put these tools in here so that you have access to maybe looking at some of the other indicators that go on in the hospital. The triage tool really assesses the patient's potential for danger and whether it may become an issue. The indicator for violent behavior is just 5 observable behaviors that indicate danger to others. And again, the danger assessment tool, this was put out by the National Institute for Occupational Safety and Health, and it's really to assess the risk to nurses and other healthcare professionals of an individual who is exhibiting signs of dangerous behavior. So these are just tools that I like to put in here because not every suicidal person is calm and depressed. You have suicidal patients who are angry, and they may exhibit some of that anger through violence. So it's real important to know that you don't have to be severely depressed to want to hurt yourself or commit suicide. Next. Here's a copy of the Columbia Severity Scale, and it basically is the logic of the clinical practice screener recently. So there's the questions and the logic that goes if they say no, if they say yes, and what you must do. And I'm going to let you look at this later on when you have the slides, but it basically gives you an idea of where you need to go when you're using that severity scale. Next. There's also something called an I-CARE assessment tool. And the I-CARE acronym is identifying the risk, communicating to everyone that deals with the patient across the disciplines, assessing the risk assessment for suicide based on the risk factors, reducing suicide by treating those modifiable risk factors, and extending care beyond the ED. So this is a quick assessment tool just to basically see what your next move is, what your treatment options are. Next. One of the biggest areas for suicide is the hospital room. You know, when you go into a psychiatric hospital, it's pretty barren. The rooms don't really have anything in them that someone can hurt themselves with. They have a very strict environmental risk protocol. But in a hospital room, there can be so many points of danger. And this hospital room, I wanted to just identify all the different areas of danger that can arise, things that you and I might not think twice about. But everything that has a point of hanging or ligature is a problem. The TV sets, the overhead beds, which is not in this room, but the overbed stands where you feed them and everything. Those are real dangers, and they're not even permitted in psychiatric units. Even geriatric psychiatric units, they're not permitted for various reasons. Fall risks as well as suicide risks. So just the hospital bed alone has a variety of ligature points that either you're going to need to put someone on a one-to-one to keep an eye on those ligature points, or remove equipment that's not necessary for that patient. So if the patient isn't on a pump, there's no need for that IV pole to be standing there. And all of these cords and all of this, they can be covered. Or if you identify an area of your hospital where you can find either each floor or a general med surg floor where you want to identify 2 rooms that you're going to make ligature proof, and then you bring in the equipment as needed. And then any patient that you may get on that floor that has suicidal ideations as well as medical comorbidities, you would be able to put in those rooms. Now, it does take planning. It does take moving people around sometimes, but those are a couple of options that some hospitals are using to be able to keep their patients who have mental health issues safe. Next. Here's another example of maybe a room in a senior living. You have the bed, you have the phone cord, the grates, the piping on the bathroom is a huge problem, and the faucets. If they are not close down to the sink, they are a ligature point. The grated ceilings, anything that can be, and you can tie anything around, paper and plastic bags versus paper bags. You know, in some facilities, psych facilities for sure, they have to be paper bags. They can't have plastic anywhere. So, you know, lampshades, if there's a bulb in that lamp, that would be a problem for people who might cut themselves. So it really takes a lot of time and a lot of planning to make something truly ligature proof. However, I shouldn't even say proof, it's resistant, it's not proof. So you just want to be sure that when you have a patient in a room like that, that there's a checklist. That's all you really need, is a checklist that says, you know, when this patient comes in this room, this has to be removed, and things can come in as needed, but they shouldn't be there and left in the room. Next. So as I was saying, we identified 2 rooms that can be ligature resistant and with suicide safety in mind. It can be used for all patients, but if you have that patient that is having suicidal thoughts, they may be able to move into that room and either have the one-to-one, or are they close to the nurse's desk? Are they away from exits to the floor so that they won't elope or run? Breakaway curtains are critical. You can't have curtains with loops or hanging devices, because all of this, while they're taking a shower and while they're, you know, not, the aides don't usually want to visibly watch someone taking a shower. but it's imperative that they do. They keep an eye on something so that they know that nothing is happening. A lot of things happen in bathrooms because that's the only place that the patient is alone and shouldn't be. So here's just a couple of things on the acute patient room safety. You want to make sure that you don't have excess furniture in the room. You don't need, all kinds of big furniture if patient's not going to have visitors. Bedside stands, they should be permanently affixed or removed if they're not necessary. What's also very important, if you can go to the next slide, is that when you have visitors that come, it's really important that the visitors know that they can't bring in certain things, and checking those bags before the patient walks in, before the visitor walks in, may be a safety issue. So it's important that everyone with that patient knows what can and can't come into the room. This is just a couple of more room safety ideas. And again, that you'll be able to get these on the slide, and you can make a checklist out of all of this. But this is what the number one goal is, to keep the patient safe. So all of these things can be adapted so that happens. Next. Here are some of the basic things that usually happen in a med-surg room as the O2 tanks that are stored, thermometers that are not necessary to be in there, they could be rolled in. Things you wouldn't even think about, the call pendant for the nurses on the bed rail, wire hangers, device pulls. So we kind of addressed all of these. What's also important is the products that you leave in the room that you really don't think about. Alcohol swabs, peroxide, all of that can be ingested. And if somebody really wants to hurt themselves, they will find a way. Next. Again, we talked a little bit about this, assigning the patient to a room where it's easily observable, but away from exits so they don't run, because there have been stories and issues with patients who are suicidal that, they're determined. They want to get out of there so they can go complete their mission. And then you have stories of, a patient who's sitting by a train station and somebody gets them and brings them to the ED, only to be discharged from the emergency department to go back on the train to get home. So there's all kinds of things that you really need to assess and think about. And I know that the basic medical professional does not have all of this training and all of this assessment ability about mental health. But it is important that someone in your facility has that to be a associate to the ED or to the medical floors when they're not sure. Using team approach, very important. Scheduling, how you schedule and who you schedule, the documentation of the patient, one-to-one staffing. These are all things that are really important to keep people safe. And the attire, limit them to a patient gown. There's no need for them to have street clothes. And if you're going to lock up their clothes, make sure they're not accessible to the patient. Next. Here are a few case studies that I wanted to share with you. We had a patient who was on bedside, one-to-one. The one-to-one was sitting away from the patient, sideways. Wasn't really visibly seeing that patient 100%. Patient asked for the blanket. After giving the patient the blanket, what was happening underneath that blanket was he was rolling up the sheet and wrapped it around his neck and tied it, began choking, and that's when the one-to-one realized that something was happening. And as I said before, if a person is determined to commit suicide, you really, really have to be on the ball and keeping them on arm's length, because all of this happened underneath a blanket that the one-to-one wasn't even paying attention to. On a psychiatric inpatient unit, here's an example where a patient was admitted because they wanted to hang themselves with a plan. They were on suicide precautions for 2 days. She wanted to get out, so she's basically telling them that she's positive. She had a plan to move out of the state, get a job. 2 days later, an ex-boyfriend calls the unit stating that the patient is texting them, telling them that she's going to commit suicide. as soon as she got out. So when they asked the patient said, oh, the boyfriend's cheating on her and he just wants her to stay in the hospital. So they reassessed. They felt that the patient had some positive plan, showed hope for the future because they were going to leave. They kept him one more day for assessment. The next day, the patient was discharged and committed suicide within 5 hours of being released by hanging. So even in your best plans, even with psychiatrists assessing, if a person wants to do it, they will say what they need to say, but all we can really do is make sure that we've done everything in our power to prevent it from happening. That doesn't mean we're going to be successful, because when they leave the hospital, we're not with them. So next. So we have some protective factors that we can look at, and they're not limited on this list, but we want to make sure that our environment is monitored. Okay, safe, secure. This is kind of wrapping up all of what we've been talking about. If they're receiving clinical care for mental, physical, substance abuse, these are protective factors. Protective factors meaning that these are positive things that may help the patient not commit suicide. So, they have easy access to a variety of interventions if they do feel like hurting themselves or committing suicide. There's some family or community support, that connectedness that I was talking about earlier. They have ongoing medical and mental health relationships. Relationships are very critical with patients who have mental health issues. They're already feeling less than, they're already feeling that they don't belong in their society or in their surroundings. So any kind of connectedness or relationship you can give them, whether it be short because they're only going to be with you for a few days, just that sense of feeling that someone actually cares about them and isn't looking at them through, a skewed kind of lens. If they have any skills in problem solving or conflict resolution, nonviolent ways of handling disputes, and culture and religious beliefs are really important. There are people that have not committed suicide because of their faith and their beliefs that, they will go down instead of up. There has been a real support for those people who have a very strong faith. Next. Sitters. We're going to talk a little bit about sitters. How am I doing on time? We're going to talk a little bit about sitters, which is usually the number one treatment option for suicidal patients, because it's easy to have somebody watching them one-to-one than someone constantly running in. But are the sitters competent in knowing what they are monitoring? So putting a sitter at a room and saying, they're suicidal, what does that really mean to the sitter, to the job that the sitter has to do? So you want to make sure that you have policies and procedures and competencies as to what should be evaluated when they're sitting next to the patient. Have make sure they have a 15-minute checkoff. What are they doing? Not only that they're awake, asleep, but what are they doing? Are they talking? Are they staring out the window? It's real important to assess their behavior as well as it is to assess, whether or not they're hurting themselves. And there should be a process for requesting sitters. It shouldn't just be, pull somebody off of another floor just to sit there. If you have a process, then the sitter job description will help you to get the right person to be there. There are multiple stories of where patients have just run out of the room right past the sitter. The sitter didn't know what to do, and they just kept going. And the reality is there needs to be some de-escalation training. There needs to be some communication training, and expectations and responsibilities. Make sure they're not on their phone while they're watching a patient or reading a paper. They need to be engaging at some point with the patient, of course, unless the patient wants to sleep or doesn't want to engage. And what is the nurse's role compared to the sitter's role in caring for the patient? What does the nurse do? What does the sitter do? And if you had the opportunity, like a volunteer program, to have someone who's in charge of assigning sitters and ensuring the compliance and identifying any of the unmet needs that are not being addressed. So sitters are very important. There's a lot of literature out there that says they're not effective. However, if trained, if prepared properly to do the job, they could be very helpful. Next. This is just a little bit more of what we were talking about. They should have situational awareness skills. Situational awareness skills are probably the best skill that any sitter can have. Know your surroundings. Know when your gut is telling you something. Know when something doesn't look right. You know, even if you think it's only you, check it out. It may not be right, and better to be safe than sorry. Make sure that the sitter is talking to the nurse. Keep that communication open. Let the nurse know what this patient is doing and what this patient isn't doing. And again, any healthcare provider involved with the patient needs to know the patient's condition, their needs. You know, patients are very smart to get what they want. Mental health patients, when they need something, they figure out how to do it. And if you're not astute to that, you can get caught up in something like a glass of water. In comes the glass, in comes the cup, or the straw, which can be all used for various reasons. So it's really important that you become aware of your surroundings and have that situational awareness. Next. Again, we were talking a little bit about the suicide after discharge. 178 per 100,000 people a year in the first 3 months after discharge commit suicide. That's a high amount of people who leave. And remember, this is from psychiatric hospitals. Okay, these are people who are getting treatment in psychiatric hospitals, have this statistic. And approximately 15 times the US national suicide rate. So I did put a link in there to bring you to the story that addresses all of this. Next. Discharge planning. When we talk about discharge planning, a lot of the times in the past, you've seen people, okay, an older person, okay, they need rehab, they go to the nursing facility or rehab facility. But when you're discharging a patient with psychiatric needs, it's not quite as easy. We have very limited resources for a quick response. They need to have a plan right away. When they leave that hospital, they need to have another touch point within a day or two, if possible. The problem is, it's the if possible. A lot of the crisis mental health places are overwhelmed. They don't have appointments. You know, the preference is within that week, but really, it should be a lot sooner than that if it can be. Make sure that the patient has a crisis plan. And, you know, crisis plans are critical because it gives that patient something of ownership to what they're writing. It basically is a plan telling them, you know, this is how I feel, this is what I do when I feel this way. And it's easy to do that when their minds are a little bit clearer coming out of a hospitalization. So it's important to do that crisis safety plan before the discharge and have numbers on it, have phone numbers on it, the suicide hotline, the lifeline, whatever that may be. Those are numbers that patient should have, and hopefully they will use it. As I said before, you can't stop that patient from committing suicide, but you can do everything you can and everything in your power to give them the support not to. Make sure the patient understands their plan, their discharge plan, and what they need to do. And you know, a good story was a patient was getting home care after they were discharged. The patient was homeless. So how do you schedule home care when a person is homeless? So that's kind of looking at the whole picture. Make sure that what you're providing to the patient is feasible. The barriers, the solutions, and the crisis center and suicide lifeline number, you know, is really important. And I know a few states are trying to make that a 3-digit number, a 988 number. It hasn't passed yet, but just as we have 911, we would have a 988 for psychiatric crisis. Next. Again, part of the discharge planning, we want to make sure that if they have access to firearms and that has been expressed as a means to their suicidal ideation, we need to make sure that some of those lethal means are removed from their house. And make sure that the relevant health information is transmitted to the providers that they're going back to. Next. These are the safe transitions we talked about, having a warm handoff. Don't just provide the name and number. Try to get somehow a warm handoff connecting the patient to the provider. And it really can be over the phone. And what I'm seeing a lot of now is hospitals having contracts or having referral agreements with some of the community mental health facilities that they would be able to provide a rapid referral. So they're engaging their community, which is great, because I think when hospitals engage their community into what they're seeing, you're all seeing the same patients, basically. So to have that rapid referral where if they do come into the hospital, they can get a quick referral and have a touch point quickly. Next. These are some of the transitions that we can have. We can have patients, have someone on site come in like they do for home care assessments or hospice assessments, and give them assistance in understanding how they navigate this wonderful system. I mean, the system has so many spokes to it. It's really difficult for anyone to navigate sometimes. So it's really important that someone tries that counseling on how to do that. And who are the people, who are the key numbers that they need to have to get what they need? What happens if you run out of medication and you can't get in touch with your provider? These are all things that are real scenarios that can happen. And again, we really do need to normalize those conversations about suicide. We can't ignore it. And it's increasing by the minute. I mean, there are people, some of our healthcare providers on the front lines of COVID have already committed suicide. And the stress is unbelievable. And if they have patients that die of COVID and they get COVID, they may feel like they gave it to them. So, there's all kinds of psychological reasons why everyone needs to be supported, and these transitions are critical. Next. So let's talk about our takeaways from today. We know suicide is the 10th leading cause of death and more frequent patient safety problem. Screening and assessment are not different, and screening should be done on every patient who walks into your hospital. Remember, it's the 2 questions. Patients who present with suicide attempts or alcohol intoxication, frequent ED visits, need a comprehensive suicide risk assessment. Denying suicidal thoughts does not mean that the patient is not suicidal, and a suicidal risk assessment should be completed. Denial alone does not reduce the risk. Reassessments, risk communication is often missed in transitions of care and follow-up. Sometimes information from the emergency department to the medical floors is missed. Oftentimes the assessments don't follow, or the key information doesn't follow. And aftercare appointments and warm handoffs must be critical for discharge planning of anyone who's assessed for further mental health treatment. Next. And with that, I am going to give it back to Liz, open it up for any questions, and I appreciate all of your time today. Thank you.
Thank you so much, Nancy. That was wonderful. Again, I think we have a couple more minutes, for questions. So as we mentioned earlier, everyone's on mute. If you'd like to ask a question, please feel free to unmute yourself. Please feel free to access the chat to pose a question for Nancy. I'll give you a second. And I see, Pam, you did pose a question in the chat. You said, I know that screening needs to be done on admission. Are there times that screening should be repeated?
Good question, Pam. I believe that screening for every change in transition to a different level should be done when that touch. So if they come from the ED and a screening was done on that next floor, they should ask the questions again. If an assessment was done, then the plan needs to be carried out on the other units. But screening, especially if they've come in with overdoses, where you don't know if it was just a freak accident or was it intentional. We don't always know that when people come in intoxicated or overdosed. So it's when they come off of the drug or off of the alcohol high that they really need to be assessed at that time as well.
Thank you, Nancy. Thank you, Pam. Again, I'll give people a minute. Please feel free to unmute yourself or raise your hand if you'd like me to unmute you, or please feel free to type any questions in the chat box.
That means that I covered everything.
Yes, it does, Nancy. And looks like we have a question in the chat, a comment from Patricia Wren. You presented some wonderful training tips. Do you have any formal competency for safety sitters or staff you could share?
Yes, I do. And I can, or how would you like me to get that to them? If you would like to email me, you can email me at nnapolitano@ecri.org with any of your questions or needs, and I could probably get you some information.
And Nancy, I'm just going to throw your email in the chat if that's okay.
That's great. Thank you.
So Patricia, please feel free to email Nancy for those specific competencies. And I will be emailing out a PDF of these slides. And I think, Nancy, you have some great links in the slides, so that'll all be, accessible. Yes. And then we also have another handout we're going to attach in that follow-up email as well.
And what I can do also, Liz, is maybe give you that competency to put out.
Sure, we can include that as well. Absolutely. And I'm not seeing any other unmuting or anything in the chat. So if folks do not have any, I think Nancy might have covered it all. Very thorough.
Thanks.
We can end a little. Mm-hmm.
They also have my email. If they think of any questions, they can feel free to contact me.
Absolutely. Thank you, Nancy. Thanks for being such a good resource.
Sure.
And I think at that we'll conclude. Thank you again, Nancy. Thank you for the presentation, for being a constant, tried and true resource. We thank all of our attendees for joining us today. HCIF will continue to provide PPC programming, and we will be in touch for any upcoming events with the PPC programs. Please be on the lookout for that follow-up email from me about today's webinar, and please be sure to fill out that survey evaluation with any feedback you have for our team. I hope you have a good rest of your day, and that concludes our webinar today. Thank you.
Thank you, everyone.